Well, yeah, it's been a really neat experience. I've had a lot of changes in my life, so I when they asked me, who I like to interview, I thought of you because I've enjoyed our talks in the past, and so I wanted to have a chance to talk to you. So thanks for doing this. So the first thing I guess I wanted to start with is just tell us a little bit about yourself and your experiences as a doctor.
Mm, I am Dr. Vipul Shah. I'm a pediatric orthopedic surgeon by training. So I did my MBBS. That's the same in Canada as well. So after my MBBS, which is like 4.5 years and 1 year of compulsory rotatory internship, wherein you travel around different departments, then I went into orthopedic. And finally, I realized that I needed something more. So I slowly gravitated into doing pediatric orthopedics, which is like trying to help children with special needs.
Oh, yeah. And
And the the science and art of logistics has been very dear to my heart. So the pandemic has been one interesting thing to do in terms of logistics, not trying to understand how supply chains work,
mhm,
how humans interact, and how do they make a difference to the supply chain.
yeah, and your wife is also a physician, is that correct?
My wife is a gynecologist.
Oh, yeah. So, and did you meet in India or did you meet in Canada or?
My wife?
Yeah.
My wife and I are batchmates in undergraduate
Oh,
course.
nice.
So we did undergraduate course together.
Huh. And how long have you been back in India?
Uh, so I'm basically an Indian citizen. So
Yeah. No, but you said
this
you educated in Canada, is that
I
correct? Yeah.
I have been, past after I finished my post graduation, I did 1.5 years of fellowship in pediatric orthopedics in India, and
Mm.
then for the next couple of years, I would spend close to 3 months, 4 months every year, traveling across the U.S. and Canada, trying to find
Yeah.
the best practices across the U.S. and Canada. So that's how I know the system in the US and Canada like the back of my hand.
And so what was your first experiences with COVID? Like, how did you first, do you remember your first knowledge of what was going on and how it affected your practice or what you did? Because I think things changed for you at that time, did it not?
Yeah, yeah. So, the first information that I remember I got was from a friend who said, "Have you, looked at what is happening in China?" So, having searched, it definitely raised a lot of red flags. And I'll tell you why the red flags were raised. See, every year we fight a viral disease, dengue in India.
Mm.
And every year, for after the rains, uh, September onwards till November, the place I live, especially in North India, hospitals are overwhelmed with dengue cases. Now,
Mhm.
my understanding was if a viral disease with a vector means a insect or uh, you know, uh, if you have a mosquito, which is there in between you and the virus,
Mhm.
uh, if that can cause, such bigger havoc every year, then if you have an airborne infection, uh, that would be colossal, strain on the medical system. So I became interested immediately.
Mhm.
And then, a lot of people have asked me, how did you gather the resources? So I have always said, the core team that I have is from my college, medical college. I am an undergrad from the GSVM Medical College in Kanpur. Now that college, you know, most of the medical resources when we started finding the team were
Mhm.
easy to find. You pull in your seniors, your juniors to, pick up the phone and talk to them, any time of the day. So that core team was always there. We did not talk to them, so regularly. But the moment we realize that this is a huge, problem which is probably going to crush us, we started getting the resources, pulling in people, because human resources were the most important thing that we could have done.
But there was a bit of a delay, was there not? Like, I mean, while Italy and some of the other countries were being hit hard, India had yet to be had a like its first wave was somewhat delayed, was it not?
Yes, yes. So I think, we need to understand that we reaped the benefits of the delay that the first wave we were, able to create. The reason, as I say it, is, lockdowns are always hard. But I think the present government was able to not only lock down early,
Mhm.
and also to, bring in people to accept the fact that, a lockdown is needed. We had
Mhm.
a pretty long lockdown. So to be able to sustain that long a lockdown was not an easy job. Uh, Most countries in the West haven't been able to sustain it for long.
Mhm.
So I would say, from the place that we were in terms of logistics, there was just one lab, across the country, which was able to diagnose COVID
Mhm.
and, get an RT-PCR for COVID. From there, uh, and we were we were a place wherein we were deficient in. I think most countries were deficient in, the overall gears that were needed.
Mhm.
We didn't have enough of N95s. Those early days were really difficult.
Mhm.
But from there, to becoming not only self-dependent in PPE kits, but being able to export PPE kits, being able to, develop technology to, produce N95.
Mhm.
That's a huge, way forward. And I think the lockdown allowed us to be able to marshal those resources and get that, crux time to not only understand the virus better, but also to, go ahead and marshal the resources required.
I saw a huge like gathering of resources here in North America, particularly from my vantage point on Clubhouse of people that were doctors who are of Indian origin who are practicing in North America, and there was a real coordinated effort to get PPE and a lot of the necessary materials to you. And I think that was it was quite an effort, and there was quite a push to gather those resources. Was that something that you were able to be part of?
I was indirectly being able to, part of, but I think, see, that was mainly in the time between the initial second wave. That was mainly during that time.
Yeah,
I think,
that's when you got hit the hardest. Was the second wave? Is
yes,
that not correct? Yeah.
yes. I think, we need to understand natural reaction of humans, and that's not, not only in India. I see that all over the globe. There's a huge number of people who definitely don't want to, get into a system which causes them emotional hardship. And
Mhm.
by emotional hardship, I want to, what I mean to say is, making some permanent changes is emotional hardship for a lot of people. For example, Japan has done really well. Korea has done really well. In fact, all the the Oriental countries have done well in, cutting
The
down
whole
the number of.
Pacific Rim.
Yes,
Yeah.
yeah. So they have done well in reducing the number of COVID cases and reducing the number of deaths. And I think, a large part of it is because 100 years ago they were able to make some permanent changes in their lifestyle. Uh, there's an interesting thing that I wanted to share. Every year that I used to travel to the US, at airports, I used to see. So the meeting that I usually went to was the American Academy of Cerebral Palsy meeting, and that was usually in the fall.
Mm.
So every fall when I travel to the US, I would see, a subset of people, uh, predominantly, Oriental in origin, looking, from their physique, wearing masks at airports. And
Mm.
I used to think, why are they, wearing masks?
Mhm.
Uh, and now I realize, wearing mask has become a part of their culture. They
Mhm.
accepted that change in 1918, 100 years ago, and that was, increased by uh, the exposure to SARS,
Mhm.
and similar outbreaks in the last 100 years, and some in the last 30, 40 years, and they've been able to uh, inculcate that habit. So
Mhm.
I think, as a human being, as a physician, as somebody interested in health policy, the ability to change and the acceptance of change, that is so important, and it interests me as a person.
Mhm. Well, I know one thing that you've talked about how there was a different approach, in the medical institutions in India, and obviously India is, I mean, a number of regions. You're very different in size and in geography, and there's a huge disparity, differences and disparities. But so I don't want to treat it like a monolith. But how does the Indian system of health all different from the United States and North America? How are they different, and how are they the same?
I think we are a perfect place to study how differences in health systems, cause changes in the lifestyle. How does it change how people behave as human beings? Uh, how much percentage of their income do they spend on health, and how does the health, what are the health benefits of X, Y, and Z system? Uh, Primarily, the India is like, as you said, we cannot think of it as a monolith. So, there are parts of India which are very well educated.
Mhm.
There are parts of India wherein the population is low, sparse. Then there are parts of India wherein the health system, delivery system is well-oiled machine.
Mhm.
Uh, so, I can compare two states. There's a state down in India, which is Kerala. Their education has been really the best in terms of outreach
Mhm.
uh, in the community. So they have been net exporters of human capital for a very long time. Keralite nurses have been able to hold their sway across not only India, but also across the whole of Middle East, large parts of uh, Australia, uh, large parts of large workforce of nurses across even Canada and the US of Indian origin comes from Kerala. Now, this state has been able to. This is a socialist, you know, predominantly socialist ideas. This state has been able to uh, have primary health centers, and their primary health centers are 3 kilometers spaced. So that's pretty, and it's a very densely populated state. They had a outbreak of Nipah virus a couple of years ago, and it's a perennial stress on the system. The system is geared to be on the lookout for that virus. And incidentally, the first cases in India of COVID were a student from Kerala who had gone to China to study.
Mhm.
He came back. And those guys were able to, this is the first documented case in Kerala.
Mhm.
And those guys were able to, find out and lock down, all those things they were able to do. And so their health delivery model, since being it's a socialist health delivery model of public health centers, uh, their death rate has been, official death rate. When I say death rates, their official death rate
Mhm.
has been one of the lowest in the country,
Mhm.
and maybe one of the lowest in the world. They've been, number of instances in the last 3 months wherein they've been able to, update their death numbers, revisit their numbers, revisit the numbers of death. That has increased, and still, they have been a model of being able to control the number of deaths as a whole.
Mhm.
And then there's a model in northern part of the country wherein it's a mash of private enterprise and the government social initiative. The Indian government has launched one of the largest schemes of health insurance to the poor. That's called the Ayushman Bharat scheme, and that has been able to, if you're poor and if you have COVID, you go to a designated COVID hospital and you get treatment free of cost.
Mhm.
So that's a lot like the Canadian system. And then we still have, the American system, Americanized system of hospitals, private hospitals. Their costs have been capped. So that's a huge difference, compared to the American system. Though the hospitals are corporate, but for COVID purposes, the costing has been capped. So i- it's a difficult situation to compare, one system to the other. But
Mhm.
overall, looking at the population that we have, I think, in spite of the problems that we had, the challenges we've had as a nation, I think we've done pretty well. I was, when we started, I was uh, a lot more worried about the numbers that would come compared to what we really had.
I think one of the interesting things is that you touched upon something that I think would influence your response. That you talked about the fact that you have experience with dengue, and like I know that in South Africa they have tuberculosis and they have AIDS in South Africa, and then that's one of the reasons they were already really good at tracking, disease, and they've had a really done really well in terms of tracking the variants and very very regimented system of tracking, and I imagine that your emergency response as a result of these other dengue for example would really heighten your awareness and make it so that you're always on guard and ready to respond
I think, the emergency response to dengue is entirely different to COVID.
because of the vector you mean.
But I think the healthcare system, that's very important.
Mm.
The healthcare system, especially in private in India, every year, as I said, we are able to cater to dengue. Uh, it does overburden our system really bad. But our internists, our intensivists, our physicians uh, have been able to work for longer periods of time. We have the capacity to manage more patients. So
Mm.
that way, our systems are geared in terms of ability. And then there's also an ability to reach out to people and have networks over finding out the middle path.
Mm.
I think
This,
that's the very important thing to do.
but I know in previous conversations you've always stressed that that's where you look for is that middle path, and one of the things that I know you and I have talked about before is the notion of treating early and not just simply waiting for people to get to the point where they can't breathe. You're looking at the ways that you could intervene before they get to that inflammatory stage. I was wondering if you could talk a little bit about, perhaps in your region, how it's different. And I know that in Uttar Pradesh, I'm sorry if I butchered the pronunciation, they've really worked hard with early treatment. And I was wondering if you could talk a little bit about that.
I think we have been able to at least convince our colleagues that early treatment is the way. That ability to convince is so important. So approximately 12 years ago, I personally championed the cause of early treatment of the side effects of dengue. And I was, literally persecuted for doing that. That thought process was not there. When you look at dengue, it's a viral disease. Creating those parallels, it would be easy for you to understand it. Both are viral diseases. Both mess with your immunity. And the side effects of both are hugely because of the side effects caused by the response of the body to the pathogen. It's not the pathogen per se. It's the side effects of the pathogen, the body's response to the pathogen, which is causing the biggest harm. And if we can, modulate those responses, I think half the job is done. And all immune diseases, all autoimmune diseases, there's a small window of opportunity. If you're able to modulate and get a handle on your body's response during that window of opportunity, there's a chance that you can make significant changes in the mortality and the morbidity. If that chance is lost, then there's no way you can come back to normal, or then there's no way you can come closer to normal without huge side effects in terms of long-term side effects. So years ago, 12 years ago, 13 years ago, there was a paper from a French island wherein they looked at the long-term side effects of dengue, and they found close to 45-50% of people have rheumatoid arthritis like side effects even up till 2 years post dengue. They followed that cohort up for 2 years. And to that, that tells me, to my mind, that what I was thinking was probably the correct path. If you have the basic rhetoric in COVID is, it's an acute disease. But my problem is, early on, I started looking at the data of the previous SARS and MERS, epidemic. And I realized pretty early on that this is not going to be a short-term issue. It's going to be a long-term issue. So disability is as important, and prevention of disability is as important, a matrix that we need to understand to take into account when we are trying to understand the health systems. Acute phase you can probably get over. If somebody has died, they are died. They are dead. And if you look at it from the health system perspective, the health system is for 3 months, 4 months, 6 months, it's stressed. But if you look at a chronic problem, the health system could be stressed for years.
Right.
And that has to be taken into account.
Yeah.
We are the diabetic capital in the world. Probably have the largest number of diabetics in the world.
Oh, really?
We are the tuberculosis capital of the world. We probably have the largest number of tuberculosis in the world. So it's a dangerous preposition to underestimate the harms caused by long COVID or autoimmune diseases which can be caused by COVID.
Mm. I know one of the things that like Bruce Patterson and Rami Yogendra are studying is the effects of long COVID on on people that have either are vaccine injured or people who have had COVID. And I know that they've said that one of the things that when individuals are treated early, they don't tend to have the same long COVID effects. And when they when they're not treated early and they get into that inflammatory stage, and even if they fight through it, that's when the damage seems to reoccur in their body, and they seem to have trouble trouble with COVID even a year and a half past their infection.
I agree. I 100% agree. In our cohort, and so when I say our cohort, it's we are a group of 10,000 across close to 40 countries. And in that group, we have a subgroup which drives the information. That subgroup comes from my college, the GSVM Medical College.
Mm.
And every day we spend like close to an hour, and sometimes maybe more than, in the initial days, we used to spend 2 hours, 3 hours on conference calls every night, trying to exchange notes. So this subgroup has had approximately 8,000 patients.
Mm-hmm.
We don't see as many long haulers in our cohort because we've treated them early.
Yeah.
And I would say, when I try and understand the causation of long COVID, the best thing that we probably did in trying to understand the causation was going ahead and vaccinating these long COVID patients.
Mm.
That has given us a huge insight into why long COVID is happening, and an insight into treating them early and trying to prevent long COVID. And there's even in long COVID, once it's there, there's again a handle of prevention that we could probably do. That's where we are concentrating at the moment.
I know that Dr. Chetty, who operates out of South Africa, Sankar Chetty, he one of his lines was that he doesn't believe there's such a thing as long COVID. He just believes there's untreated COVID. And I thought that was an interesting way of looking at it. One of the things I wanted to ask is that you are not against the vaccinations. You actually are a proponent of them in some cases. And I was wondering if you could speak to how you would decide on risk and risk benefit regarding the vaccines, and also the variety of vaccines that are available in India compared to other nations like the United States and Canada.
I think, we need to understand the world has become polarized, and that's the worst part of the pandemic management that we've been doing. It's either masks or no masks. It's either vaccines or no vaccines. It's either early treatment or no treatment. And that's the worst thing, to do in a pandemic. The virus doesn't understand, the political differences which drive these discussions. The virus is only concerned with its own propagation. And as humans, we should be able to do everything in our arsenal to prevent that propagation, prevent the harm, and mitigate the harm caused by the virus.
Mm-hmm.
So I definitely, when I say walking the middle path, I am, when I say I think I'm speaking for the group. The group is 100% pro-vaccine. The group is 100% pro-early treatment. And the group is 100% pro-masking. And when I say masking, it means N95 and nothing lower than that, because we've been able to, as we, the situation changes, as our information is changing, we have been able to tailor, our experiences and our uh, responses to what is the emerging information, to be tied to a dogma is the worst thing to do at this point of time.
Mhm. So where do you see, like, one of the things that the demographics in India, I mean, obviously it's a huge country, but compared to the United States, I know the obesity levels are much lower, but you said that the diabetes levels of diabetes are higher, tuberculosis as well. How have the demographics of the nation affected the success of treatment? And I know that at one point there was a real issue with um, the black fungal.
Yes.
Oh, I'm drawing a blank.
Mucormycosis.
Reaction. Yes.
Mucormycosis.
Yes. So how have the differences between the nations and like, for example, water quality, pollution, all these things, how is that factored into the relative success or failure of treatment?
I think when I say we do this or we do that, it's a difficult situation. Looking at uh, not only the demographics but the underlying health status of an average Indian. An average Indian has never been able to, consider health as their priority. For us, there are other things. We are a developing country, so those other things are a big drain on our resources. And health does not, reach that level of importance for an individual. I would say pollution is a very important determinant. We have a baseline issue of pollution in North India. Uh, we also have a baseline, as I mentioned, diabetic issue. We also have, as I mentioned earlier, a baseline problem of tuberculosis. Now, putting all of it together, I think the younger age group of our population has made a big, significant change in our statistics of death and disability. And the other thing that I wanted to say was the other important determinant of death rates or statistics of death uh, is our family value system. During the first wave, so we are, a system wherein approximately 40 to 50% people live in multi-generational homes. That is a blessing and a curse. When you talk of COVID responses, I would say curse because we have smaller homes, our population density is more. So if we currently know that the worst place to get COVID is at home settings, indoor settings. So if a family member brings COVID home, then there's a very high chance that the other family members would be infected. And if you live in a multi-generational home, one person gets it, and then there's like 10 or 12 people getting it from the same person. The other, when I said curse, so I've explained why I would say it's a curse. But when I say it's an advantage, I think I would need to, tell you interesting stories of, people who've lived in multi-generational homes. 9 people, 10 people in a home, everybody gets COVID except the elderly. So during the first wave, specifically, we were able to shield the elderly like crazy. The kids and the elderly, they did not go out. They did not, everything was provided to them in the confines of homes. And that gave us, a chance to prevent those deaths.
Mhm.
and a chance to vaccinate them and prevent the deaths in the second wave.
Mhm.
Uh, had that not happened, we would have seen much more higher number of deaths in India than we saw. We have been seeing currently.
I know one of the things that people often early on were very critical of what happened in Sweden because of the choices they made. And I think, they often look at when I hear Anders Tegnell talk about how he, the one thing he wishes they'd done differently, he wishes that they had protected their elder care homes better. And I think in certainly in Canada and the United States, this was also an issue. But I think that's one of the positives about the multi-generational home is that you keep those individuals out of a system where they could then be around other people that have been infected and they're all immunodepressed, and that's going to create a problem. And I imagine though also one of the benefits of the multi-generational home is that if someone gets COVID and you can treat it early, is that you can now treat the whole family and you could get everyone that same treatment to support them. Would that not be the
Okay.
case?
Yes. Yes. So early on, even during the early period of first wave and more during the Delta wave, the second wave, anybody who got COVID, one positive, especially in the second wave, we understood Delta pretty early because it was starkly different to the first wave. In the first wave, I have anecdotal information of so many of my colleagues, husband and wife staying in the same room, uh, you know, same house, and one of them was infected, the other was not.
Mhm.
Strange, but that was the infectivity.
Mhm.
But in the second wave, early on we realized, one person infected means the whole family infected. So it
Mhm.
brought home that uh, you know uh, lesson pretty early on that the Delta is infectious, and probably over a period of time we will see more infectious variants coming in.
Mhm.
And we started to treat the family as a whole with early treatment, irrespective of what their RT-PCR said, irrespective of what their lateral flow test said.
Mhm.
We would treat them at par with the same protocol, with minor changes, obviously, but the
Mhm.
protocol remained the same and the investigations remained the same. Uh, so we were able to prevent, you know, a large number of people worsening, and that's a significant gain,
Mhm.
because the health system was stressed,
Mhm.
and if we could prevent those people going into the system, into the hospital system, I
Yeah.
think we made significant gains in you know overstressing and preventing the overstressing of the hospital system.
Yeah, and I think it seems obvious, doesn't it, that that would be, you talk about that middle road, and you've referenced that so many times in conversations you and I have had, and I think that that seems to be a very obvious thing to do, to just not just treat the one individual, not send them home and hope for the best, but to give them something to treat them and treat those around them. I'm wondering, how is the tracking? You mentioned the recorded deaths earlier when you were talking about the southern region of India. I wonder, how has the tracking been of COVID, of, for example, something like natural immunity, vaccine injury? How has your tracking system been for in all those different aspects and throughout
I
India, or
think
is it region
I
to
think
region?
I think we've had issues with tracking, and I accept that upfront. Tracking needs a lot of resources. Tracking needs a lot of you know support systems
Mm.
already in place. You cannot start a system of tracking in the midst of a pandemic and expect it to do well. So our community tracking systems are definitely an issue.
Mm,
But when it comes to hospital tracking systems, I think we've done well.
mm,
Especially, the corporate hospitals have been able to do well, but that's a segment of the population. We need to, understand that segment of the population may not be uh, representative of the whole population.
mm,
And that's where, there's an advantage of trying to understand the Kerala model of tracking. They have had their own issues, but thankfully they've not had huge issues of oxygen. You know, we had issues of oxygen supply
mm.
during the second wave, and I think and that was primarily in North India. Kerala had the advantage of not having that second wave in conjunction with the whole of North India.
Mm,
So they learned their lessons from North India, and they were able to streamline their oxygen supply.
mm.
I think learning from good experiences of others and bad experiences of others across the globe is so imperative
Mhm.
across the globe, especially in a pandemic situation.
How have you found that like the governmental bodies or institutional bodies have how open have they been to looking at early treatment? Because this is one of the big issues in North America is that there has been institutionally a lot of friction and a lot of tension regarding early treatment. How is it? Has there been any suppression, or has there been any difficulty in
No,
bringing forward those options?
no, truthfully not. Uh, our physicians have been given a very long handle in treating COVID. The government definitely does, form panels, and those panels evaluate the options available. For example, we've had hydroxychloroquine in our official treatment protocols. We've had ivermectin in our official treatment protocols, and those were incorporated pretty early on. And when the treatment evidence did not show apparently too big a effect of ivermectin, they were dropped.
Mm,
But that does not stop me or anybody to not prescribe ivermectin or not prescribe hydroxychloroquine. I think allowing the person who's affected the chance to discuss with their care provider and take a joint decision on what to do has
mm.
been one of the salient strengths of the Indian system, uh, at least till now.
And what has been the most effective protocol from your perspective that you've been using that you think has shown benefits?
I think the most effective protocol has been a fluid situation. So we've kept on adding things, and we've kept on dropping things as evidence kept on increasing. For
Mm,
example, let's say about hydroxychloroquine. Uh, Early on, we added hydroxychloroquine to almost all patients that were being treated.
mm,
And then when we realized, when those papers, clutch of papers, came in JAMA, one of those papers that were retracted. I think we were the first group to stand up and say, we've been using hydroxychloroquine for generations in India for treatment of malaria.
mm,
It doesn't cause deaths as as is being portrayed.
mm,
Uh, that helped retraction of those papers. But having said that, uh, you know, uh, after the later evidences came in, we dropped hydroxychloroquine treatment in the early stages, and there's a big group, in India, which uses hydroxychloroquine after the acute phase has passed to
mm,
prevent long COVID, and to treat long COVID.
mm,
Uh, it's an autoimmune process, so if you treat it early, you use steroids early, you use hydroxychloroquine early, you can prevent the long COVID process settling in. So
Mm.
that's been a big change in one of those. I'm giving you an example. That's been a change in one of those things that we did. Similarly for ivermectin, we've used ivermectin for close to uh, maybe a year or so, and we've used it in large numbers. We definitely don't see any harm of it.
Mm.
But the problem, as I see it, is we've used so many things in conjunction to not being able to tease out what's the
Right.
respective
Yeah.
efficacy of X versus Y or versus Z.
Yeah.
So
Well, that's one of the
for
problems,
that,
isn't it? That people are trying to find this magic bullet. And really, it's a multi-drug therapy, isn't it? It has to be
yeah,
a spectrum of drugs and
yeah,
all, vitamin D, vitamin C, zinc, and all these things working in tandem to regulate the immune system.
I would say, looking at just one thing, just one medication, whether it helps, whether it doesn't, that hasn't, we if that were the criteria, nothing except steroids would probably work, you know. But
Mm.
then when you reach that steroid level, it's probably an acceptance of the fact that you've not done a good job early on.
Mm.
If you do a good job early on, probably you could reduce the number of people who would need steroids or the amount of steroids that were needed. So I would say, incremental addition of strategies is a more, better way of treatment of COVID early on than just saying, we will not do anything till this proves to be very effective.
Right.
That's the worst thing to do. So we've done the whole gamut. We've done vitamin C, vitamin D, ivermectin, hydroxychloroquine, we've fluoxamine, cyproheptadine. We've used, statins early on. We've used aspirin early on. So we've developed one whole protocol that we
Mm.
start, pretty early on. And I'm saying when I refer to me, I would say, it's always us. So we get uh, information from so many sources. For example, Farid Jalali was the person who started the thought process of the serotonin pathway, and I and Farid were in contact, and we were not initially in contact, and somebody referred, this guy, he's speaking of the serotonin system. Why don't we look at it?
Mm.
So I and Farid discussed this, and we said, this looks interesting. And
Mm.
we started using cyproheptadine. And similarly for Angela Grayson, Angela and I were a part of another subgroup. And then she told me that she's found this. And then we looked at the experiment in the race course that happened,
Yeah.
of the early use of
Fluoxamine.
fluoxamine.
Yeah.
And we said, this looks interesting. And I and Angela were, back and forth, back and forth. And then we added Farid, and between the three of us, we were back and forth for not more than 3 days. Those were 3 very intense days. But finally, we were able to tease out of both of them the best possible strategies and immediately apply to our patients.
Mm.
And I'm sure we saved a large number. And when I say I'm sure, uh, I can give you an example. There was XYZ patient. We had an issue of oxygen,
Mm.
whose oxygen saturation was 83, 84.
Mm.
He was not able to find oxygen for 10, 12 hours. So we gave him uh, both fluvoxamine and cyproheptadine, in
mm,
addition to other medications. But when we added cyproheptadine, his oxygenation reached 90.
mm,
So from 84, without oxygen, we were able to reach 90. Now, to that information to my mind tells me that it does make a difference.
mm,
Uh, though we were not able to maintain him, because you definitely need oxygen,
mm,
uh, you know, for somebody who was at that point of time, at that level. But the ability to hold that level from 84 to 90 for a couple of hours gave us some time to arrange oxygen.
mm.
So those are instances which tell me uh, we need to keep on adding things, and if we find something which is not working as well, we drop it.
Mm.
We need to be a little more flexible in accepting that this is working and this is not.
And I wonder, like, you do wonder how many deaths could have been saved if we had had a more universal approach to early treatment, and we were looking at, even if we're not saying, oh, this is completely efficacious, still, implementing, ivermectin along with other drugs, or hydroxychloroquine along with other drugs, and knowing that there's not going to be a detrimental effect on the body, but in some cases it might prove beneficial. And I think that would probably, I think, even if you just look at the comorbidity of anxiety and fear, that would, feeling like you were trying something and that there was some attempt to set your body right, would help people recover. I just wonder how many deaths, what percentage of deaths might have been reduced by that.
I agree, but having said that, uh, I would say we have been blessed in terms of by the government, in terms of not throttling our ability to prescribe.
Mm,
And then also, I think we have been blessed because we've been able to get vaccines in time. uh, there was a lot of vaccine hesitancy early on, even amongst physicians, but the advent of the second wave changed everything,
mm,
and the vaccine hesitancy reduced, uh, in a large percentage.
mm,
And when I say our cohort, approximately 99% of that cohort was vaccinated.
mm,
So I think that helps us to understand, you know, the difference that vaccines can make.
mm,
I would say, hadn't it been for the vaccines, we would have been worse off.
mm,
So early treatment in conjunction with vaccines is probably the way forward, and we need to keep on using the Swiss cheese model. The bigger problem in the US and large parts of the world is trying to force XYZ vaccine.
mm,
And I think having talked to tons of people on Clubhouse and other social media platforms, I think people have genuine concerns over a new technology. I I understand that concern, and my middle path has always been that people need to be given more, uh, a larger bouquet of uh, uh, things that they could probably take. For
mm,
example, if I give you know uh, the people who've not taken vaccines the option of taking Novavax or a kill virus vaccine,
mm,
I would say a large number of people would take it,
mm,
much larger. So to uh, club everybody who's not taken vaccine as vaccine hesitant is not right. I would say there's a large number of people. No, to say that uh, everybody who's not taken a vaccine is anti-vax is not right. I would say a large number of people is vaccine hesitant. And I think that number of vaccine hesitant could be hugely reduced by giving them more options on the table.
Mhm. I think one of the things that I've like, I know that in Canada right now we have two options. We have Moderna or Pfizer, and that's it. They've removed all the other options. I remember when you and I discussed this previously, you were surprised by that. But I wonder, and I similarly feel like if it's not that people are vaccine hesitant, they're in a sense vaccine selective, and that they have concerns. Do you have any concerns about the messenger RNA or the vector-based vaccines that we're seeing from the AstraZeneca, the J&J, or conversely the Moderna or the Pfizer? Have there been any safety signals in India over those vaccines?
We haven't been able to access Pfizer or Moderna in India.
Mm.
We've had two major vaccines. One is the killed virus vaccine, which is Covaxin, developed indigenously. And then we've had the Johnson vaccine, which is almost coming in. We've had Sputnik vaccine, and then we have the larger bulk comes from Covaxin, Covishield, which is the AstraZeneca vaccine. We are the largest producer, So once if I look at it from a personal perspective, my whole family has been vaccinated using the AstraZeneca vaccine.
Mm.
And that also includes a large percentage of our group of 10,000. Truthfully speaking, amongst our group of 10,000 and their families and their extended families, we've not seen the side effects, big side effects that have been purportedly, spoken of. We've had, one instance of somebody who probably had AstraZeneca vaccine and who went to the UK and had probably a drop in her platelet levels. One case in approximately 10,000 direct and maybe 100,000 indirect cases that we know of. So 1 in 100,000, if I extrapolate what I know, 1 in 100,000 is too less a number. We personally know of, before the AstraZeneca vaccine was brought into India, we had close to like 750 healthcare workers dying in the first wave.
Mm.
And with vaccination, in spite of the Delta, we had like another 750 die. But hadn't it been for the vaccines, we would have definitely seen 3 times more deaths amongst healthcare workers in India. You look at the numbers of deaths in healthcare workers in India versus the US or the UK. We have had like close to 1,400 healthcare workers dying in India. The US has like 3,600 deaths. The UK has like close to 1,500 deaths, and they have much lesser numbers compared to us in terms of population.
Mm-hmm.
So I think the mass pressure, and I would not ascribe it only to vaccines. I would say a combination of both, early treatment and vaccine. That has probably helped us keep our number of deaths down majorly. And across that number of 750 or 1,400, I have a number of 1 who had to be hospitalized. I would definitely any day take the vaccine.
Mm. And how is natural immunity recognized in India? Like in your region, for example, is there any acknowledgement? Because one of the things that I've been questioning is why, if at a certain point, if the vaccines are precious in terms of prioritizing who would get them, you would have thought that we would have looked at people who were acknowledged as having recovered from COVID as being put down in the prioritization to allow people who have not been infected to be vaccinated. What is your thought in that regard?
I think our group early on, we championed the cause, writing to the health authorities, writing to the Prime Minister of India to accept people who've been infected, to go a little further behind in the in the line for vaccine.
Mhm.
Uh, and we also championed prioritization of people who had comorbidities.
Mhm.
So irrespective of their age,
Mhm.
so I think that allowed India, along with coupled with the fact that we had initial issues with the number of vaccine doses available, to prioritize people who were at risk getting it early, and people who had been infected getting it a little late. So definitely, I would there's enough information available to say that people who've been infected and who've been vaccinated, both, are at a much better level compared to people who have not been vaccinated, or people who just got natural infection. I can tell you from an anecdotal example uh, from my own family. So uh, my wife uh, and I live with my parents, who are like uh, 72 and above. So we, before the vaccine came, we did our anti-spike antibodies. They were not there before the vaccine. Post the vaccine, our anti-spike antibodies were 100. Okay, my uh, my wife and I were like 250, and my mother and father were like 60 odd. So I would say, a rough average would be 120. Uh, now we all, in spite of what we did to prevent the infection coming in, during the second wave, my wife was still, infected, and that brought the infection in. But we started, since we were vaxxed, and uh, we were already on early treatment. We were able to, prevent us going to the hospital.
Mhm.
My oxygen levels dropped. My father's oxygen levels dropped. My father's oxygen level dropped to 90, and mine dropped to 93, 94.
Mhm.
But we were able to manage at home.
Mhm.
Hadn't we been vaxxed, I am sure we would have needed to go to the hospital.
Mhm.
Having said that, post the infection, we again checked our uh, anti-spike antibodies. Mine, from 200 odd, jumped to approximately 14,000 odd.
Wow.
My father's, from uh, 60 odd, jumped to 16,000 odd.
Wow.
Okay, so and then we followed it up.
Yeah.
As I speak now, yesterday we have given our anti-spike antibodies again, to try and understand, before the Omicron comes into India, we want to understand where we stand in terms of our immune level.
Mhm.
I accept that, antibodies are just one part of the immune uh, protection that we have, but that's probably the most important part,
Mhm.
because the antibodies are the first line of defense, uh, especially with the Delta coming in.
Mhm.
The virus is able to shorten the time when it replicates, especially with the Delta. What happens with the Delta is the virus replicates so fast that it reaches a very high peak in day 2, day 3. Now
Mhm.
the body needs time to, if you don't have enough antibodies, circulating antibodies, the body needs time to produce those antibodies. in response to virus, and that comes at around day 4, day 5, day 6.
Mm.
By that time, if you do not have enough circulating antibody, your immunity will help you. But by that time, probably it's been, we've lost a chance, and then there's a higher chance to side effects caused and long COVID caused, even if you don't die.
Mm.
So that's why the fact that early treatment has to be combined with uh, vaccines, or you have circulating antibodies present, whether it's by vaccines or by natural immunity, but you need to have a good repertoire of circulating antibodies present to
That
be
was
able to control.
one of the things that I would like to see is that we maintain a control group of people who have not been vaccinated, have had COVID, and see how resilient and how robust their antibody, especially their B cell and T cell immunity is over time, and whether that ends up in a reinfection or not. I think that would be critical to have that, track that, and to see, because right now, in a sense, you're diminishing that control group by providing vaccines for that group. And I understand in some instances, especially when comorbidities are high, that you would want to avoid that, because you don't want to roll the dice on your own health. But I do think there's a place for that that existing control group to see how robust that natural immunity is.
I agree. We should do it, but the problem that I see it, trying to maintain that group is ethical, and then there's another issue, there's a guy called as a PhD guy who studies T cells. He's Mr. Leonardi. He's done only T cells throughout his life. His PhD was on T cells, and he says that he doesn't find T cell immunity to a level to hold off recurrent infections. And when I speak of recurrent infections, I also need to say that the virus is an evolving continuum. So what we know, or the rules that we set today, may not be the rules that we will have to follow in the next 3 months or next 6 months.
Mm.
The virus will keep on evolving, and we need to keep on updating both. As I said, we need to keep on updating prevention. We need to keep on updating treatment. That includes early treatment, and we need to keep on updating vaccines, and we need to keep on updating our understanding of what can be used to prevent in terms of lifestyle. So all those things are is a hodgepodge. It's a big cauldron that we need to continue working on.
Has there been any I mean, I'm not familiar with, in terms of mandating vaccination, has there been any programs in that regard in India, or have they been just sort of promoting the vaccines and allowing people to make their own choices?
I think early on, there wasn't any mandate. Healthcare workers were very hesitant initially, and then when the second wave came, everything changed. The uptake changed like crazy, from like 20% or 30% all the way to like 75, 80%. At this point of time, we have like close to 82, 83% of Indians having taken the first shot.
Mm.
And we haven't been enforcing the mandate as strongly. So there are talks of mandate, but nothing which has been very strictly enforced. And think at some point of time, governments will not mandate everything, but there's definitely a push.
Mm. How do you feel about that?
I think if I were be given just one choice of a system, either you take Pfizer or Moderna, both mRNA vaccines and nothing else, I would be very hesitant.
Mm.
I definitely want choice. Having said that, there's you know I need to tell you, my family has been vaccinated, as I told you earlier, with the AstraZeneca vaccine. My kids
Mm.
have been vaccinated in a trial for a killed virus vaccine, which is the Covaxin. And now, if I were to jump at that point of time when I took that decision about uh, getting the kids into trial, if I were forced to take the mRNA vaccines for my kids, I would have been hesitant.
Mm.
But now, as more information comes in, my hesitancy level has dropped a bit. But still, Covaxin or the killed virus vaccine is my first choice, especially when it comes to kids.
Mm. And why is
So,
that?
what did you say?
Why is that? What makes you less hesitant about the Covaxin rather than the messenger RNA vaccines?
I think we need to, as human beings, understand there's nothing like uh, running away from COVID. Whatever we do, everybody on earth will get exposed to COVID multiple times in their lifespan, and at least twice or thrice in the first 3-4 years. We just cannot prevent that happening.
Mm.
What we can prevent happening is uh, prevent it. We definitely know that the initial shower of the virus is very important. How much virus load do you get initially is so important to the pathophysiology of what happens later. And
Mm.
that's where good masks, and when I say good mask, nothing less than an N95 mask.
Mm.
But if not an N95, definitely using surgical masks uh, is the bare minimum after facing the Delta wave. So 2 surgical masks or an N95.
Mm.
So coming back to the basic again, the initial question, we know that we cannot run away from the infection. Now, if given the choice between getting a natural infection and an uncontrolled natural infection over which I have no way to control how it will behave, and I have a way to modulate the response of my body, whether by vaccine or by early treatment, I will definitely take that option. The vaccine allows me to have circulating antibodies trained, available to be able to block that infection and prevent it from reaching a much higher level.
Mm.
I have no control on which direction my immune system will take. Will it take it normally and be able to control the infection? Will it go awry and go the way which can cause a cytokine storm, or will it go the opposite way and cause suppression of the immune system? I have really no control over it. What control I can probably have is prevention of it reaching to a level wherein uh, it goes into an overdrive and causes cytokine storm. And the way, as I see it, preventing that is by doing early treatment and by having enough levels of circulating antibodies to reach that level.
Mm.
So in my mind, there is no confusion. Having an vaccine and having circulating antibodies and using early treatment and using masks are all equally important. Now, having said that, uh, it since I know that there is no way I can control the virus, a vaccine which is a killed virus, to my mind, will definitely give my body information that this is the outer covering of the virus, and this is what you're going to uh, find in a couple of days' time.
Mm.
This is the enemy that you're going to find. It's like, doing mock tests before the final examination. I think a mock test, anybody and everybody would understand. A mock test is so important to a preparation for an examination. A simulation, study is so important before an examination. So by giving a kill virus vaccine, I am doing a simulation study. I'm doing a mock test, reducing the chances of harm. So in my mind, a kill virus vaccine would be the best
Mm.
way to introduce the viral proteins into your system.
Mm.
There's always a discussion of the side effects of S protein. There's no way we can run away from the S protein. The only places we've been able to fend preventing the virus getting into have been to some degree in New Zealand, in Australia,
Mm.
and they have been forced to open up. You cannot remain closed to the world throughout your life.
Yeah.
So at some point or the other, you have to open your gates and allow the virus in. But
Mhm.
before you open the gates, your armamentarium has to be perfectly well-oiled machine, ready to reduce the harms caused by the virus.
Yeah. I think that's the thing that really I've really questioned over this whole experience is then, this notion of zero COVID. I think that that was unrealistic in the way that our world is open and we have, such movement throughout the world. I just thought that zero COVID was, unless you had an island nation where you could close your borders, you could seal yourself off. But even as you say, you're going to have to open at some point, and you need to have a strategy to do that. But I think also one of the problems is that we use such blunt instruments. And I'll give you an example. In our old age homes here in Canada and the United States, you would have a vaccine program where they would come in and they would vaccinate everyone in the home. And then you have all these people with this depressed immune system for that maybe that 2-week, 3-week period afterwards. And they are, there are people coming to visit and everyone's, interacting with them. You could have people who are dying of a common cold because their immune system has just been dropped down to such a level. And I think if we had targeted it better, maybe said, okay, we're going to vaccinate a few people here, and then we're going to isolate them, keep them safe, and then we're going to isolate another. We're going to isolate another cohort within a home, and that sort of targeted thinking would have been much more effective. And it seemed that we just kind of wanted to sweep through with the vaccine without any real thought of the impact it has. And I just wonder what your thoughts about that. Like, I mean, what would you say would be something that occurred in India that you think you could have done much better, or you could have approached in a different way? Hindsight being 2020, how could you have done something maybe differently?
I think that's a very interesting question, I would say. And why I say that is, we need to understand political systems. So, though China was the first country to report COVID, currently they've been able to approach zero COVID, and they probably will be the country which will uh, carry on with the program of zero COVID the longest.
Mm.
And that's because uh,
Totalitarian.
system.
Yeah.
So uh, you know very early on I said, maybe close to a year ago and maybe a little earlier, I said there is no way New Zealand can keep COVID entering its doors. China has proved that it has been able to control COVID to a very large extent, and I don't see any democracy being able to do it.
Mm.
That's because there are variant voices in the democratic system, and until unless we do not bring all those voices on the same table, it's not going to happen. Uh, Speaking of India, and I think that's where we've been able to make major inroads. For a huge country like ours to reach 84% vaccinated, eligible elders vaccinated, that's a huge you know uh, achievement, I would say. And while I give the government's 100 points on this, I would also give the opposition equal measure of points. And why I say that is, early on there was a huge fight between the government and the opposition about uh, who would get the vaccines, how much would be the vaccines.
You've cut out. I can't hear you, Vipul. Sorry. You've gone mute.
Yeah, once the vaccines came in, I think in the initial days, uh, this herd immunity concept was still prevalent.
Mm-hmm.
The opposition thought that the government wanted to take the credit for rolling out the vaccine, and they said it's the party specific vaccine. All governments across the globe will want to take the credit of rolling out the vaccination if they think it's for public good. But I think the opposition also has to play a constructive role in coming on the table. And I think the moment the opposition said this is a government vaccine and we will not take it, I think our group jumped onto uh, the scene and said, it's not just the government's vaccine. It's a program run by the government, but it's the people's vaccine. It's the scientists who've created that vaccine. So that narrative was nipped in the bud that it's just the government who's doing this vaccination and it's the government's vaccine.
Mm.
That narrative probably has not been, nipped in the bud by a large number of governments across the world. The governments across the world have not been able to engage with the opposition, and I see, some part of those mistakes being made by professionals as well. Whether it's early treatment, whether it's vaccination, whether it's masking, there's a small percentage of professionals on both sides who will say, I will just do this because of their political beliefs, and they will try and politicize uh, the issue.
Mm-hmm.
Now that doesn't help you in the long run. We have voices in the US uh, who speak of who are physicians who speak of masks, and they are sternly anti-masks, they are sternly anti-vax, they are sternly pro early treatment. And then there are the opposite group who are pro vax, anti early treatment, pro vaccine. Now those two groups keep on fighting on Twitter. In 2018 or 2019, there was an interesting paper uh, which was published, which said, that rogue governments across the globe aren't interested in promoting vaccines. Uh, there are, bots involved. Those bots are used by rogue governments to prevent anti-vax sentiment, and those bots come from. We know, for the Western democracies, we know that they come primarily from Russia and from China. So, and also, the North Koreans have been, further drivers in those discussions, those bots. Similarly, then the opposition latches on to early treatment, and for them it's only early treatment and no mask. That's probably not the way out.
I think, one of the things I think it's interesting about what you're saying is that, like, I think one of the things that has caused this sort of, rigidity in thinking around, vaccinations and the fearfulness with regarding with the public is the censorship and the depression and suppression of early treatment in North America. In Canada, you're not even allowed. Physicians are not even allowed to talk about early treatment. They're not allowed to be. They obviously can prescribe hydroxychloroquine for something like arthritis. Or you could prescribe ivermectin for scabies, but they don't want you prescribing them for COVID. And you look at Australia, where they've actually made ivermectin illegal for prescription. I think this is one of the things that, as you push people and say you can't hear about this, then I think what happens is there's this Robin Hood effect, where people start to say, why don't you want me to know about that? Why can't I learn about that? And so it has the opposite effect. So I've said that, I'm of the belief that the governments in Canada and the United States have done more for vaccine hesitancy through censorship than anyone else could have possibly done, because they have really limited the discussion of these things in a free and open society. And it sounds like India has done a better job of saying, no, we're not going to vilify early treatment. We're going to allow it. And so then people don't feel suspicious, and they make sounder medical decisions in conjunction with their physician. And I think that if they know their physician is free to recommend whatever is best for them, they're going to be more prone to take their advice.
I think we've been pretty open about it throughout. Our system has its own advantages, our system has its own disadvantages. For the whole period of the pandemic, having treated so many patients of COVID, I was able to see them from my home over a phone call. You just need to tell that patient, if they are not educated, just go to the nearby pharmacy and give the phone to the pharmacist. And the pharmacist could dispense the medication without me seeing the patient physically. Now, those liberties are so important. And I think, a large part of, those liberties stem from the fact that, our system has, in terms of, vilifying, we've not been vilifying our doctors as much as that has happened in the US or large parts of Europe, for example. See, you have to understand it from the physician's perspective. If the physician is fearful of lawsuits, then they're not going to do anything which harms them. And that's the problem with the US system at this point of time.
Mm.
And that's the problem with large parts of European system at this point of time. You make a mistake, and when you treat people, there are things that are going to happen for no fault of yours.
Mm.
Now, if you drag each and every of those cases to the lawyers for compensation, then you have it. So I understand why physicians in the US are fearful of trying something or anything new till there's a randomized controlled trial proving the benefit.
Mm.
Now, the problem is, in an emergency situation like a war, or uh, you know uh, like this pandemic, there's not everything that you can prove by doing a randomized controlled trial. For example, you go to a war and you think, if I shoot from this position, I will be able to kill the enemy. Or if I, shoot from that position, I will be able to kill an enemy. Or if I use this, what is more, how many more bullets will I use if I shoot from that position?
Mm.
If you keep on deliberating the efficacy of the number of bullets that you spend, the enemy will get you.
Yeah.
And that's one major problem. I think the biggest problem that Western societies have been facing is trying to use the same strategies that worked in non-war times.
Mm. We're
I
not
think
we're not
there has,
we're not applying triage really.
yeah,
We really should be
and that
triaging.
I think those triage points belong to every step in the decision making, whether it's for the vaccine, whether it's for early treatment, whether it's for any other decision that we are making in terms of public health decisions, especially in the early days of the pandemic. And now, the rhetoric has gone to a point wherein people have, uh, you know, dug huge, they fortified their positions.
Mm.
And then the moat is so huge that there are no bridges that can be built.
Yeah. That's one of the things I think is like we've gotten to this point where for many people, the vaccine is the only answer. And you look at people, with mast cell disorders, POTS, these are people that don't have that option. And we cannot be putting someone in a position where they're jeopardizing their health, knowing that the vaccine could harm them. I think that's a really dangerous thing. I want to touch on something that we haven't talked about, because I think it's important for people to know. On a personal level, COVID has been very difficult for you, and you've described to me what happened with your wife and yourself, because your wife being gynecologist, what she had to do, and maybe you could talk about a little bit about that sacrifice that she was forced to make for a long period of time.
Uh, See, as I said, we live in a multi-generational home. There are advantages, but then there are sacrifices that you have to make, to be living in a multi-generational system, society. So the moment COVID came, uh, and we realized it early that we need to shield our parents. My wife works in a setup wherein she has to see 100 patients at least every day, and these are women, pregnant women, large number of them uneducated or not well educated. So there's always, I was 100% sure that she will bring the virus. There's no way we can run away from the fact.
Mm.
When the virus enters our house, my mom is asthmatic. She used to be very obese. Now she's cut down on weight. Uh, and my dad is like also pre-diabetic. So we understood the risks. For one full year, my wife stayed in an adjacent room in the house, cut off from the family. My kids are 10 years old, twins. So they were able to talk to my wife only on, WhatsApp, or on video chats. Uh, and we were able to speak to each other, see each other across 18 feet. I would, put the food outside her room, and we were, you know, so for our mental health, we decided, we are going to spend half an hour every day speaking to each other in an open space, 10 feet apart, both masks. So, it's difficult. And what I realize is, from my own experiences, if you have somebody away, and you know that they are away, I think it's lesser of a issue compared to if you can, see and expect people, and that 12 feet gap or 18 feet gap is a much difficult, gap as a human than maybe a couple of miles further off.
Yeah.
So there are layers of, emotional issues attached to, the problem.
Yeah, that's quite a sacrifice you had to make. And I mean, the first time you told me that story, it was shocking, but it was a testimony to you and your wife of how much you wanted to protect. She wanted to keep treating people, but at the same time wanted to protect your parents, and that is incredible.
And I think
That
I'm
is
not
not.
the only person. I'm
No,
not the
I'm
only
sure.
person who's done
Yeah,
that.
yeah,
Tons of doctors across the world have done that,
yeah.
and tons of doctors in India definitely have done that. They've been, doctors who slept in their cars, slept in separate rooms uh, for months before the vaccines came in.
I wonder, you do wonder what will be the long-term effects, of the lockdowns, on people's mental health, people's social interactions. I am concerned about children and how, in the long run, this will all affect them. There's a resiliency, obviously, but I do think that obviously missed cancer screenings, addiction to drugs. These are things that that are going to cause death down the road. I mean, these will not be immediate, but suicides. These are all the things. And I one of the things that is always fascinating me about Vipul, about our conversations, is you're always talking about the middle road. And I think that that's something that in our postmortem of COVID, I think will be important to look at in our examination of the public health response, will be all of the aspects that we haven't really fully even taken into account, and how that will how that will affect our future response. Because someone once said to me not too long ago, they said, I said, how do you feel about COVID in retrospect? And she said, I feel fortunate. And I think that would shock a lot of people. But she was thinking, her point was, what if this was the 15% fatality rate of SARS-CoV-1, or the 50% of Ebola? We would be in a very different position now. And in some ways, we've been fortunate to have it not be as, not as much of a catastrophe as it could have been, because the virus doesn't have the fatality rate that of those other viruses. And so I think, in the postmortem, we're really going to have to look at all aspects of it. And I think that'll be interesting to see what the reckoning is from that.
I agree. But when you speak of, deaths or suicide, I want to bring to your attention, an interesting fact. You look at what happened in New Zealand. When we speak of lockdowns, they've been under the longest lockdown. Australia has been under the longest lockdown. Interestingly, the number of suicides in Australia, the number of deaths in Australia and New Zealand has been lower than average. The number of deaths in New Zealand have been lower than average. I think when we speak of deaths and suicides in the US increasing because of lockdown, it's probably because uh, we did not have a good family system, to start with. And secondly, we did not have a good community system, the rallying of the community against the common enemy happened.
I don't want to take too much more time, but I did want to talk about one thing, and that is you wanted to end on a high note. You wanted to end on a positive note because in a prior conversation you had talked to me about that you're hopeful based on your research about past pandemics and past viruses that you believe that that we're going to see an end. Now, obviously, you're not saying zero COVID, but you think we'll be able to live with this at a certain point, and we will see a petering out of it. And I was wondering if you could just speak to that as sort of a closing to our discussion.
I think I have a background image on my laptop, and which says, "This too shall pass," and that gives me, a lot of hope. Looking at the history of all viral pandemics that have happened in the last thousands of years, we've not seen a viral pandemic stay for longer than 3 years. And the only pandemic that has stayed for more than 3 years is the HIV pandemic. But this virus is neither HIV, nor is it, does it have the ability to, the science has changed, and we are putting in money in terms of treatment. And, when I speak of hope, I speak of trying to understand our immune system like a textbook. So when you read a new textbook, the initial exams are always difficult. Sometimes along the line, sometimes you may have a question which may be out of the course, and that's what the new virus was. And then you have sometimes, the examiners asking you a question which is hidden from the normal. You have to deduce what is happening, and that's what the variance will be. But if you keep on reading the textbook multiple times, you would be able to understand what the writer is trying to say. And that's where our immune system, that's exactly what our immune system is doing. It's trying to understand the virus. And looking at the past history, I think we have to understand that the virus has a key and a lock mechanism. The key is the viral part, and the lock is the ACE protein. Now, the key has to fit into the lock to be able to open the lock. The spike protein has to go inside the ACE receptor to open the ACE receptor. And now the spike protein is mutating. But there will be a point wherein further mutation of the spike protein will cause it not to fit in that lock of the ACE protein. And that's where we will hit the pandemic coming into an endemic phase. The speed at which this is happening is where I look at it as hopeful. The virus replicated fast to gain an advantage in terms of being able to infect more people with the Delta plus, now the Omicron. That speed is going to reach, and probably has reached, a level wherein it can go no further in terms of speed of infecting people. And then comes the ability to jump host defenses. by changing the number of proteins or mutating the number of proteins present in the spike protein. That's what is happening with the Omicron. And I think with the Omicron and maybe one more, I'm not too sure, but I think, with the Omicron and maybe one more, we would be reaching a point wherein the virus will be forced to accept the truth. The truth is that it will not be able to mutate any further without latching on to the ACE receptor. Now, there's a caveat to the statement, and I think early on I expected it to happen in and around Christmas. We are reaching that point. The Omicron has reached appeared exactly on the scene wherein I predicted months ago. And further from it, further down the road, I think after the Omicron, we will see a reduction in the numbers of variants, which will cause a new, entirely a new question to come up before our immune system. Having said that, there's only one caveat. The caveat is, increasingly in the virology circles, I see discussion about the virus being able to grab parts of human, the mRNA or human genome. That's not an unusual situation. 5% of our genome, that happens both ways. We grab a part of the viral genome and the viral genome grabs a part of our genome. That has been happening since ages. And what I fear is, and that's the caveat statement I want to make, if the virus grabs hold of a part of the human genome, which allows it to develop an alternative pathway of entering the human cells, other than the ACE protein, then we have a different, a new set of problems on hand, and that could probably potentially lead to a new pandemic altogether. Currently, I don't see that happening, but with this virus, we could probably, But having said everything, I think the 3-year mark is where I see, hope, and I see that happening, another 6 months or a year.
Yeah. Well, hope would be a good thing. I think, although, I've heard it said that I remember a headline months ago saying that COVID is now worse than the Spanish flu. Well, 30 million people dying in, just over 3 years. That was a much more severe situation, than this one. But this has been horrific, and it would be great to sort of embrace that hope. And I hope you're right. So thank you very much for doing the interview. I appreciate it. Dr. Shah, is there anything in closing you'd like to say? Just any last remarks?
I think the last remark comes from what you said, just a second earlier. I think this pandemic would have been as worse, if not worse than the Spanish flu, had it been for two things. One is the wide availability of oxygen. The ability to give oxygen has made lives much more possible. And the second thing is the ability to control our responses, use of steroids, has changed the trajectory of number of deaths in the pandemic. Hadn't it been for these two things, we would have been maybe worse off, because this pandemic has, human interaction probably at the highest ever seen in all viral pandemics.
Well, on that note, thank you for doing this. I really appreciate it. And I hope you and I will get to talk again sometime. I really appreciate it. And thanks for doing the interview. And all the best. Thank you.
Take care.
I hope you enjoyed this episode.
Please note that neither the host nor the guest have any undeclared conflicts of interest. Please visit novametricsinc.com for more information about the Canadian COVID collaboration.